Okay, hello.
Good afternoon, ladies and gentlemen, and a very warm welcome to this World Implantology Summit. I hope you are all staying safe and well around the world from wherever you're watching this. My name's Andrew Hobbs from the World Dental Council, and I would like to extend a very warm welcome to you all to be a part of this virtual summit, the World Implantology Summit 2020, hosted by the World Dental Council of International Implantologists and sponsored by Europe's leading dental implant brand, IDC Dental Implants, and Antea SRL of Italy. The World Dental Council is a registered premium international non-profit membership organisation which was founded with a vision to promote dentistry around the globe, managed by WDC Dental Research and Association. We have over 4,000 international dentists under each speciality of dentistry, and WDC provide international membership for qualified dentists and accreditation for universities and dental hospitals around the globe to connect, communicate, network, and excel. Dr. Charulatha, who is a leading entrepreneur and dental surgeon, is the president of the World Dental Council. And Dr. Andrea Tedesco, who is the leading zygomatic implantologist and dental surgeon, is the vice president of the World Dental Council. It comprises 8 speciality councils, which include implantologists, orthodontists, prosthodontists, endodontists, oral and maxillofacial surgeons, periodontists, digital dentistry, and aesthetic dentistry. And today it is the World Dental Council of International Implantologists who are very proud to host this 3-day webinar series with renowned international implantologists from Italy, from Egypt, and from Brazil. So our sincere thanks to all the 500 plus dentists who have registered to join us for this event from all around the globe. Your verified CPD certificate link will be sent to all registered participants at the end of the summit. And if you're not currently a member of the World Dental Council, then please visit worlddentalcouncil.net and be a part of this global mission. So without further ado, time to introduce our first speaker. We will take questions at the end of the webinar, so if you want to send your questions in, we will put those to our speaker at the end of the session. But let me now introduce Dr. Alexander Salvoni, who graduated in dentistry from the Methodist University of Sao Paulo in 1993. He has a PhD in oral pathology from the University of Sao Paulo, and he's an international speaker and specialist in implantology. So presenting today's webinar on the topic, technical modifications in the approach to zygomatic implants, please give a very warm welcome to Dr. Alexander Salvoni.
Thank you, Andrew. I hope you are hearing me very well. If any problem with the sound, please just say. I'll try to fix it. And I'm very glad to be here and get this opportunity to speak for all World Dental community. And I'd like to thank you for this organization in a very difficult time for all the world. And this initiative is very, very, very important for everybody. Because it will be the new method I see in the near future will be the many events we have done in the past. And so it's very interesting to have people like you and the WTC organizing these kind of situations and even putting everybody together, sharing knowledge. And this will be faster for everybody to add some knowledge. So I like new technologies, although it's a little difficult for us because I graduated already quite 30 years and we are always updating cameras, videos, Facebook, Instagram, and now the live concepts, what is very interesting for us and a very good challenge. So I'd like to share my my presentation. Let's see if it's could you able my sharing my screen, please. Hello, Andrew. Okay. Okay. So I believe my screen is shared already. Okay, let me see here. Here's the man. Okay. So we discuss mainly in this lecture the techniques about the zygomatic implants. We start from the initial concept, and I try to bring some new concept and the clinical applications, and maybe discuss some complications about the technique. And we know that zygomatic fixtures were originally designed by Professor Brannemark in the 1989, and initially this was recommended for mutilated patients after maxillary resectivity procedures. And on a second situation, Professor Brannemark proposed these fixations also as an alternative of bone grafting procedures for the maxilla. And the original technique was done in conjunction with 2 to 4 conventional implants on the anterior region. This may still as the main recommendation, but as requirement of this, we need some bone on the anterior. Okay, you cannot see my screen. Why not? So I need to start again. Okay, now you can see. Much better now. Okay. Now you are, Sharu. Thank you. Good. So I start again. Thank you for this invitation, Sharu. Thank you for the organization, WDC. And I'm very glad to be here, sharing some knowledge with you, and also part of my history, not only about the technique. So we discuss mainly the techniques, as I said before. On introduction, I apologize for some I'll be repetitive, just on these first slides. So zygomatic fixtures were developed in 1989 and for maxillary resectivity procedures. And on a second situation, Professor Brandmark proposed these implants also for atrophic maxilla, avoiding some bone extrusion before implants. And his original recommendation was to add at least 2 implants on the anterior region or 4 implants. But we see some changing or modifications on this original concept, mainly by these, because we need as requirement some anterior bone on the anterior region to follow this recommendation. And we easily can find more resorbed maxillas where you cannot find, even on the anterior region, this bone. So, since the beginning of this challenge that was the modern implantology, a couple of patients, mainly the atrophic patients, the dangerous patients, wasn't untreated. So once the Zygoma technique came to the scientific or dental world, the philosophy is spread through the world dental community very, very fast. And a large number of specialists get engaged to do some modifications from the original technique, trying to add some improvement and trying to reduce the morbidity of the technique, and also a best result on the prosthesis. So only in 1999, Professor Brandmark presented a research, and he published on this research and work he did around or including all the clinics, Brandmark clinics from the world, and this is about 183 implants, 12 years follow-up, and a very high success rate. So on this original approach, used to include the lateral window, also in the beginning, do some membrane lifting and many times adding grafting material. By the years, we see that even Professor Brandmark left the grafting material because probably you are adding one more kind of complication on your intervention. More you do, more complication you are able to have. So we see on the last decade, many authors trying to configure it differently by the situation they found on their patients, trying to add some, let's see, immediate load, what in the beginning was not supposed to do, okay? Also trying to do the quad Zygoma configuration, and maybe some authors using 3 implants on the same Zygoma, change the type of angulation, adding some new guides, and more recently we see you have more time spending on the virtual planning and trying to do it guided. Okay. So Krekmanov in 2000 proposed the hybrid configuration. That means different way to do the all four, mixing with the zygos. Bedrosian is one of the first to recommend intravenous sedation. So in the beginning, even me, when I started the technique in 2004, at least for 3 to 4 years, all cases I used to do was under general anesthesia at the hospital. Sometimes I go to the hospital, I still with this kind of intervention too, but once you reduce the indication of general anesthesia, you improve the number of patients or the patient's acceptance. So this is very interesting, is very important, but initially can be interesting for some colleagues because it's a little easier with the patient sleeping. We have a more calm situation for the surgeon, let's say. So we see Malavez in 2003, a very high success rate, and mainly for Latin community, the most used measurements of implants is about 4 to 45 millimeters, but we start with 30 millimeters, and some companies nowadays, they are offering the option of even to 60 millimeters, okay? So Botor in 2003 tried to add 3 zygomatic implants in the same site or 3 bilaterally. And you see also Malo and Miglioranza in 2004 to 6 approach with the all-4 concept. So they worked on the all-4 standard, all-4 hybrid, that means 2 zygomas and 2 conventional implants, and all-4 quad zygoma. But we see nowadays that this concept is decreasing a little bit because most of my colleagues, I can see, they really do not feel comfortable or see the rehabilitation as a long term when they only do 4 implants. So actually, we are discussing to improve the number of implants. And for sure, if you can do 6, is more than 4. So these will be more long-term result for the patient. It will be more comfortable for the patient because we can also see some complaints about the patients when they have only 4 implants. So Duarte is a Brazilian author also who started to do in 2000 really early immediate loading only in 4 zygo fixations. And Bauchi also did a very good prospective study with a great number of the zygoma fixtures in various success rate. And you can see in 2008, 7, and after 5 or 80 years for Brandmark, for sure, or more than 80 years, people start to get word about satisfaction, patient satisfaction. And this was about really about the volume, the palatal volume of the prosthesis. And most cases following the original Brandmark approach used to have a lot of palatal volume. So this brought some patient to dissatisfaction with the rehabilitation, and most authors start to really care about the emergence profile of these prostheses and the position of the neck of the implant, bringing this more to the reach. Okay, and a lot of discussion occurred on this time because We had the Stella concept. We discussed a little ahead. See here the original approach from Professor Brandmark. If you look for the original in the beginning, used also to do a left for one incision, okay, and just one releasing distal incision each side on the first molar area. So we changed a little bit this incision because this became really difficult, mainly if you are using sedation, not general anesthesia. And also we adapt this sequence of drilling because from the round drill to 2.9 twist drill is really difficult, and the possibility to break the bone, to break the zygoma bone get higher. So most of systems also have a different sequence of drilling. So we can see from 30 millimeters to 55, okay? Some systems still with this, from 30 to 40. The variation measurements are about 5 millimeters. And only after 40 millimeters, we see a variation of measurements about 2.5. This requires some attention when you select the system you work. And this was the beginning, initial recommendation for implants, and in addition to the two zygomatic implants. So we can see here the incision we are performing until nowadays. Where we add usually a release incision in the middle, because this making the attachment of the flap we can do faster. See the lateral window. This was to push the membrane, lift the membrane, and also to control the trajectory of the drill, okay? So even you can see other authors trying to modify the technique. This is a concern about all authors, because we need to control the drilling process, avoid damage to other areas like the orbit. And so we cannot lose this drill inside the sand, because if you lose direction here, you can go below the orbit. And around the orbit, the bone is very dense, but the orbit floor is a very thin bone, and we can find some really complications. About the apex positioning, still not a concern even nowadays, because we see colleagues following this recommendation, and this was for sure if you are doing one zygoma in combination to 4 or 2 implants in the anterior region, conventional ones. Okay, you can cross the full body of the zygoma, no problem. You can use this main area, the full body, and you get a very hard bone, and the availability is the highest you could find. But what occurred with some experience is, once you lose the anterior implants, and this is very important, because when you do an implant on this bone, you are using D1, D2 bones. So the bone you have in the anterior maxilla in atrophic cases are very thin, or the density is not the same. So when you look on long term, On long term, you can see that can be easily to lose the conventional implants. And now, if you need to solve the case, adding a new zygoma, it's a problem if you cross the full body with one single implant. So from the beginning, I start to share the zygoma area in two parts, zygoma 1 and zygoma 2. But even now, nowadays, we cannot see described this situation. And for this important, reason is important to invest in education, because some things are not on the books, and events like this, the Congress, are important by this, because we talk and the books just stay there with a great amount of theory and knowledge, but it's different when we speak. And so you can see the neck of the implant here, very palpably, and we'll see in the next slide some modification about this. So in order to simplify the original technique and improve the prosthetic positioning, Stella and Warner proposed some changes to the original protocol. So they try to use a round burn, making 3 to 4 holes and then building a slot to control the trajectory of the drill and the implant, and reducing the need of a window. Okay, this slot was just for orientation and no concern about the membrane. We could perforate, we could try to keep the membrane intact. What was quite impossible, because when you use a 3.3 millimeters drill inside the sinus, even you lift the membrane, probably you perforate it. So the advantages the author used to refer was about this reduction in surgical time, for sure, if you're not grafting, not lifting. And this better placement was not on so much. This was a little more to the ridge, but still in the palate, in the palate. So greater bone, I don't believe so. Elimination of the need for sinus lift, for sure. Okay, and this is beautiful when you can seal the entrostomy, or this is not, you can really set your implant here. You can seal the entrostomy with the implant board by itself. But this was the problem, main problem of the technique, because sometimes you do this lot like this, but your implant go like this. So you start with this and finish with lateral window. We can solve many cases that occurred this. This is perfect. You can see the trajectory here. Probably the implant on this situation, you see the area. So you can see the difference from the window. I could say Bredorsen like to do a very big window and also to graft still with this approach. I prefer this one, more simple, but I have to say you need some experience to achieve this result. For a person who is starting with the technique, is not so easy, because internally this bone have a curvature, and the drills can slide inside easily, and then you change direction. So what I say to my students usually is let the drill work, because If you go very, very fast inside here, then your cut the bone more apically, so you lose the position. Okay, see melhorança in 2006, try to make it more externally, what is interesting, but also on his literature or his book was not so clear, because he referred these only in case you have a concavity. Sure, is really typically found in atrophic maxilla, but some case this lateral wall still convex. And when you see a little ahead in his book, you can find that some case the fixation is partially internal to the maxillary sinus. So what you are doing, which concepts you're following, okay? What it means to be inside and external, but this is not total, especially. So again, this is a stellar approach. And on this situation, we do not see modification. So he only used to do total external when was concave and no ridge. So what he was really doing was an anatomical approach. So, and this was not so well settled in the literature. And this is the main work from Aparicio, where you can see his classification. And then he tried to involve all situations you find. You find patient with concavity and bone, concavity, no bone, and then you go more external with your implant. So his classification is very interesting. Is one of the points of the literature we concern actually about. Maybe you could reduce the way you do the approach, but the anatomy classification for zygomatic anatomical approach is very, very useful to refer. And you see the type 0, the maxillary wall is very flat. First anatomy is placed on the residual alveolar ridge, so means that you have some ridge. You go intrasinusously to the zygoma body. And type 1, you see more concavity of this lateral wall. Okay. And some little modifications by the anatomy, more presence of ridge, less presence of ridge, more convexity of the lateral wall, okay? And then you can see type 3, very concave situation. You can see the implant go extrasinosally. And then when we start to do cases like this, type 3 and type 4, we start to see some advantages. And this was interesting because once we start to do cases like this, we start to have less complications with sinusitis. And then we start to have a brainstorm, and why not to approach all the cases like this? If the main problem on lifetime of these implants is to avoid the sinusitis problems, we could do all cases like this. So this was very, very interesting, and we keep in mind on this in about 2008. Probably most of authors start to find results like this. And you can see here, both in 2003, the first one to propose this situation. What I really do not recommend, because two implants is difficult, to try to do three is more difficult, but you know, you can see people still trying this, and is used to recommend the first implant on the second molar area, and for this you should use also infratemporal approach. Okay, so you go from distal to infratemporal, and you see how you hit the body of the zygoma. The middle implant is the one that goes directly to the body, and the anterior go from the nasal area to more close to the orbiter, or the lateral margin of the orbit properly. Okay. So this is the situation. Okay. And we can see a recent post in Dental XP website where a colleague pointed a little bit different. So we can see these all three implants looking to the same direction. But to have this availability, you can see here, is not easy. And then we have a question about the distance between these implants. Okay, here the distance are good, but apically you see convergence. So how able you are to really keep bone in between these implants? So maybe we could do another conventional implant here. And also we need to see that literature says if you have 4 and in addition 2 implants conventionally is sufficient. So why should I risk myself, the patient, and trying to do another one more? Maybe in the future, because I see for this situation to do 3 implants on the zygoma, maybe in near future we can see some companies trying to develop a thinner point or 3.3 implant apex, maybe. Then you can try more this kind of situation. Okay, the Krickmanov approach and the Duarte approach in comparison here. And this is the situation I was discussing before. Crossing the full body with this, as the original recommendation, can be very big, can be very compromising in the future if you lose the conventional implants here. Now, how can you do another here? You have no distance. And this occurred to me, one case we have done in the faculty. I need to detach the orbits to control the implant insertion. And for sure, you have some visual alterations in the beginning from the patient. He had diplopia for 30 to 40 days. Then everything became normal, but initially it was a huge complication. So usually I used to refer this as wrong for my students. I do not usually approve this position, but you can see easily in the literature, many people doing these both configurations. Okay, so all of these configurations, if you can, try to add two conventional implants, or in the anterior region, or in the pterygoid area, posterior area. Okay, once you try more implants, you get more stability in long-term aspect. Okay, so this is the first modification of the Zygoma implant design. Boys and Varley, they are connected to Southern Implants company, and they start from the beginning to try to modify these, adding some angulation on the neck. And then you see other company also modifying the neck, trying to make the angulation on the abutment and not on the implant. What I see is some advantages on this, because if you want to modify this positioning of the neck, sometimes you have to twist. You need to give a complete turn. So imagine that you are trying to achieve torque and you didn't achieve torque, then you need one more turn. And now you finish this turn, I get the torque, but now you say the connection is not in good position. And now you need to go ahead, because if you go back, you reduce the torque. So once you try to go ahead, giving and twisting all the implant, one complete turn, and then you can have some complications, like broke the mounting implant, broke the bone, and not easy to solve these complications. Okay, you see in 2008 the first guided surgery, but talking with Saad is a Brazilian colleague, in a congress, he said, I wouldn't try it again because he did this surgery flapless, for sure. If you go through the palate to the zygo area, okay, this is empty space and you have not so much problem. But if you have a deviation of the surgical stent, on the way you fix it, you have no flap, you cannot control the drill, so the risk to go here inside the orbit, when you put, like for example, two zygos, and like this image here, it's a little dangerous. So we have a very good concept now. You see in the last slides that you can do it guided, but we use the flap. So the discussion about which technique is purely academic, okay? And you can see mainly is the surgeon preference, okay? So the rehabilitation in immediate load system, I recommend more long-term follow-up, okay? I understand that is easier to patients acceptance this point, but we don't need, you can use dentures. So do you really need to do immediate load? I see on the maxilla, on mandible, in most cases, 99% I do the immediate load, but for the lower, the upper, I see a lot of remodelation. And if you have some teeth extractions, you see more and more remodelation, even because some cases you need some bone leveling. And so considering also the budget of these patients, that they want to pay for one prosthesis, maybe you can see a really good alternative to follow the initial recommendation. Just put the implants, and on the second stage, will take only 3 months, 4 months maximum. You can rehabilitate these implants. So for a patient that used for 20, 30 years the same denture, what is 2 or 3 months? So even nowadays with the pandemic, coronavirus, where people are using masks daily, where most people, elderly people, are at home, so it will be easier in the near future to not do the immediate load. I know that is really, really difficult to resist, but I changed my approach, because in the first decade I used to do these implants, I used a lot, or quite all cases, in immediate load. And then I saw some benefits avoiding the immediate load. I will show ahead with some clinical case. So just to remember, initially was not recommended, and the insertion torque, usually exceeds 50 newtons, so you fulfill the requirements for immediate function. And this is the discussion, is not because you fulfill the requirements, you should do it, okay? Is still your option. And most authors, for sure, even me, I believe that it is important to study the original Bradmark surgical approach and dominate it, okay? Maybe you don't need to do a patient using the original Bradmark, but buy 2 or 3, 4 plastic models, or even you can use the patient model, because you can print the patient model, print 2, okay, and do the original approach to understand where it will be the main part of the body, the Zygoma body, and then you try to do or to approach with other technique. For sure, if you can do it vocally, as I will show on the end of this presentation, you will reduce surgical time and morbidity too. So modifications is still necessary. When you ask me which implant I use, which implant I recommend, I can say to you that we didn't finish this development. All the time you see new modifications, new designs, and we need to use all them, okay? What people are concerning, this was a mistake for some time, occurred when Nobel Biocare tried to introduce the treated surface for zygomas. I see this is not a good idea. And they changed recently, and you can see most companies, they are doing machined surface, at least for the area that you go through the sinus, and I should say treated surface just on the apex. And my position is this is even to the conventional implants. I don't know. My first implants on the 90s, all machined surface. So I don't see problem with machined surface. So in 2012, something really interesting happened. I start just to do all cases externally using just the slot technique. And I met Professor Morris Salama, who I invited to come in Brazil and do this surgery. I hope you have sound of the video. I don't know, because sometimes we need to do some modifications on the configuration of the Zoom application. So here's Professor Salama. We are in the hospital. Okay. Can you hear the music too? So you see, you have an even projection of the surgery and the video. You cannot see the. So someone need to habilitate on the Zoom app. You have a place that you can put available the music. You change the configuration. Okay. We go ahead. If you are not hearing the music, I still speaking. You can see doing the slot with round drill, like Stella technique, but we will not approach the ridge on this area. So it's just to find the cortical bone. And the trajectory. And something interesting also is transfix, just to control the direction. You can see the tip of my depth gauge. And now the implant. You see the second one completely externally. You see the depth gauge there. You can touch, you can feel, you can see, using the pilot drill. So when you see this, the anterior implant and the posterior implant, we see that the anterior implant, no discussion about you go inside or go out the sinus, because you go all time out the sinus. And even cases like this that you see no bone on the neck, then we need to ask ourselves, what is the importance of the buccal bone on the neck? Because it's a very thin bone that will be resorbed in the first 2 years, for example, and we sacrifice the implant position doing this. So then you are doing this palatal approach, this very little palatal approach, and just to keep some ridge here, but this is so thin, and now you see that you risk to have sinusite is higher than put the implant outside completely. And this is the problem we find when you do externally, but it's better to have some implant recession than to have sinuses, because the recession you can manage with brushes, but the sinus, sometimes you need also to remove the implant. Okay, so this is a little repetitive. I have another 2 videos to show you. And now you see the benefits to not use the immediate load. This is the same case after 3 to 4 months. And I just use a punch technique to find the implants. We can do the impression. Nowadays, you can use the trios or the peak digital devices, or can still using the conventional technique, and you capture the denture position for biting, registration, take measurements, and here we finish with a very, very healthy result for the gum. So this is the reason that I really try to recommend people to not do the immediate load, because when they do immediate load, it is not easy to find a health gum like this. And you see, this is completely external from the bone, and you can see that you can keep a good tissue around, okay? But it's just immediate, no 8 years follow-up. And you can see little recession, you can manage this easily, and patient is still happy. And something occurred 4 to 5 years ago, when Dr. Dan Rosen and Dennis came to Brazil. They brought to me this diamond burn from Norris, and then you have the perfect, the perfect modification of the slot technique, and you can see it doing everything outside from the sinus. We start nowadays approaching the zygoma directly, like a conventional implant. So they simplified too much the technique. You can see here a surgery on my specialization course at São Paulo with my students. And I'm not doing the surgery, I'm filming the surgery. My students do the surgery. This is a Brazilian system we use here. I'd love to have a IDC system or Norris system here in Brazil. It will be huge. Okay, you see, we did some study on the plastic model of the patient, and then my students go directly to the zygoma body. Use the slot burn and follow the sequence. Is just like the conventional implant. You have a sequence of 2 or 3 drillings, 3 drills, and this is interesting also because some companies can, you see the positional three-dimensionally. Some companies do a reduced number of drills because they have different or reduced protocols for drilling. So this permits also some modifications on the threads of the implant. Let's see. Okay. Without music again. No problem. So this is the sequence, but mainly you can see that you do not start with a very big round drill. We use in the beginning a spear drill, a starting drill, very, very thin, like a very thin depth gauge. And the zygoma with this slot drill always fit in the same trajectory. Okay, so really, definitely, you have no more window. Okay, as I said, in Brazil, most cases I do not follow immediate load, but this I did on Italy at Salerno, Santo Bassalo Clinic, with a very, very interesting system that is from the same region of my father. My father is Italian, from Lucca, and luckily I found an implant company there. Is the company that now is sponsoring this congress. So I would like to applaud them for the initiative and also for the system. And we did the same technique with not diamond but carbide one, okay? There is a cross-cut drill, and they have also like a spear drill for the beginning. And this approach is very, very interesting, okay? So you just need to start on, or to study better the anatomy of the patient, and then you start to have eyes to look where is the good part for your implant, okay? This is the necessary knowledge to do the zygo implants, conventional implants on the anterior region. And here you can see again the drill. And let's see in movement, because my time is finishing. And I know this is a breachy event, and people are on time always in England, okay? So here you see the incision, contouring the teeth. You are doing the flap, and you start drilling. And you see the drill works as the same as the diamond drill. And a reduced sequence of drilling they have. If you feel that the taste is not good, you just use two drills. You see the implant, no treatment surface, no threads on the neck. Very interesting, internal connection. They have a new design, but I had no opportunity to try this new design, but it's a beautiful design that I believe it will work very, very well. So we put the multi-unity abutments for immediate load. We covered all the buccal wall with some hemostatic collagen membranes. And Dr. Santivassalo and his technician performed the same-day treatment for the patient, okay? We did it in this day other two cases where he followed to do the immediate load. So Dr. Dennis Ismail and Dan Rose, my partners in US, they recently used the virtual planning and guided surgery. So you see a guide for bone leveling to adapt this titanium guide, okay? This is interesting, new technology, but I have to say a little expensive because this metal guide is difficult. You need a laser melting machine that can melt the particles of titanium to build this. So became expensive. So the implant positioning and abutment connection to immediate restoration. And you can see, imagine 3 implants on the same Zygoma. They are really close. I'd like to thank all my Brazilian students from these 20 years giving lectures in Brazil, and even to all my international students, Portugal, Italy, Spain, UK, Australia, New Zealand, and recently people from Japan and China, also Taiwan. They built all my confidence, they built all my skills, and also to all my patients that I could do them happy with our treatments. And to finish my conclusions, I can say the zygomatic implants offer adequate retention. We can practice reduce the number of implants in this kind of rehabilitation. Is a predictable treatment with shorter time and less morbidity. Excellent alternative for the severe atrophy of the upper jaw. And sure, we need to see the age, the history of the patient, also the anatomy, to choose the appropriate technique. And all these things will influence in the case selection. I hope you will see what you can do for the future of the old dentures. And I'd like to thanks again Dr. Sharu, Dr. Andrew, and also the IDC company, IDC company, for this beautiful event and this big opportunity to spread my word. Thank you, Andrew. Feel free to
Professor
finish.
Salvoni, thank you very much for a fascinating talk. We have a few quick questions from delegates who've been watching the talk, if I may. Firstly, from Dr. Sajid Hussain, who would like to ask, has there been any impact of the COVID-19 outbreak on zygomatic implants?
Sorry, could you repeat again?
Yes, so Dr. Hussain would like to ask, has there been any impact of the COVID-19 outbreak on zygomatic implants?
Sorry, Andrew, the impact of?
Can you hear me?
Yes, yes, the
Okay.
impact of?
So Professor Dr. Sajid Hussain would like to ask, has there been any impact of the COVID-19 outbreak on zygomatic implants?
Oh, I see that the main thing is about the preference of each author or each colleague. So I don't see so many advantages of this. Actually, what I'm doing and using is what I showed you. 90%, 99% of all cases exteriorized, and we can do both approach, immediate load, not immediate load approach. But main thing is straight the gum. So we need to select a good surface around the neck of these implants and middle portion. And prosthesis profile, this is the more important thing, because we need to change the way we see the zygomatic implants. We need to see as we see the conventional implants. It's just implants, okay? One benefit more you have here is that you cannot lose these implants by periimplantitis, okay? You will not have any bone resorption on the apex, or so you do not lose retention by the ears. So something interesting, sorry Andrew to be so long on my answer, is in the beginning, 2004, when I started to do my first case, and you ask yourself, this is for how many years? Which will be the long-term results of these fixations? And I said 5, maybe 10. And now they are arriving to 20 years as my conventional implants. So they are like conventional implants, and we need to simplify the approach, the technique, uh, we are running quite on the perfection with the technique nowadays, with IDC company and Norris company in the market. They have the best design, the best concept, and maybe some people are introducing less volume on the neck to have less resection. Is this okay? Next question.
And our next question comes from Dr. Anish Kumar, who would like to ask how much bone should be removed during the lateral window?
The minimum as possible, or none. This is the point, because the drill permits you just take the bone as the same size of the implant. Even if you want with this system, IDC or other one, okay, you can use to do the slot, lateral slot, not to do in a window more. You use the drill, so it's perfect. Using this kind of slot, you do not need to remove. Is really straight the implant size. And what is interesting also, you preserve the membrane naturally you preserve the membrane. Good.
Thank you. Our next question comes from Dr. Anwar Ashraf, who would like to ask how insertion techniques exceed 50 NCM.
If you follow the sequence of the manufacturer, and this is interesting because on the beginning, as in 2004, immediate load was the fever, really the fever around the world, in Brazil, all parts. The immediate load, the immediate load. And I saw colleagues that they took this decision during the surgery, because before I do my first surgeries, I start to see colleagues doing zygomatic implants. And the surgeon decided, I will not use the less drill. I said, on my head, what? Why you do not decide to use the less drill? Because I want torque. So the consequence of high torque is broke pieces, your drivers, your mounts, the implant, and even the bone. So all these complications when people exceed not 50, but when you exceed 70 newtons, all pieces start deformation, and they are susceptible to fractures and even the bone. Thank you.
Thank you very much. And our last question comes from Pirani Murali, who would like to ask, can we use a natural tooth for the implant?
Natural tooth? Sorry, can you repeat?
Yes, of course. He would like to ask, can we use a natural tooth for the implant?
For Zygoma?
Yes, I assume that's what Pirani means. So.
Is outside from the ridge. I didn't understand so much this question. About natural tooth, or let's say extraction in doing implants. No problems with anterior teeth extractions, but the problem is if you have a big extraction and on the area of the first molar or second premolar, where you set the neck of this implant, probably you have oral-throat communication. And what I suggest sometimes in this case is you before the surgery, take these molars at least. If you have molars, take the molars before the surgery. Let the gum, just the gum, heal for 60 days. Then you can do the surgery and you have no problems. But it's very, very riskful. I will not say that I never had this situation, but it's very, very riskful and difficult, this situation. If you have a first molar extraction, doing the zygomatic implant to do a first closure of this soft tissue is not easy. And maybe you have an indication to rotate the fat pad over the implant, blocking some oral-throat communication on these cases. And I don't know, you have one more question?
Just got one more very quick one, which is again from Dr. Sajid Hussain, who would like to ask, how long do zygomatic implants last?
We don't know, the same of the conventional, full life, whole life. IDC have a very good slogan, is implant for life. Companies do implant for life. I do implants for life. Patients want implants for life. It's for life. But I will do one more question, because some few years ago, as we have a colleague that used the fat pad. All the surgery, he rotates the fat pad over the buccal aspect, the implant. And all the cases he do this because this is to avoid the resection, avoid the complications, or guarantee the first closure. Okay, to guarantee the first closure, I have to say is try to avoid the immediate load, because then you really suture the borders of the incision. Is the main attitude you can do to guarantee first closure totally, avoiding immediate load. And this is something that is interesting, because I would have more time to show you a case I did recently, where the patient was having oral-throat communication by a Zygoma implant, 5 years, and bilaterally oral-throat communication. And to solve the case, I remove the implants and I rotate the fat pad to close the oral-throat communication. So if in all my cases I use the fat pad, so in a case that I have a problem in the future, I do not have more this resource. So this is the point, because nothing, non-technique is for all. It's the same, zygomatic is for all patients. No, for most patients it's conventional implants. For elderly patients, patients who don't have, I use the zygomatic implants. And to rotate the fat pad is very, very good technique. Is really useful, and this is really indicated when you have situation that you have the risk. If I have the risk of oral-throat communication, I use it, but I do not use this technique. I do not rotate all fat pads in all cases. Okay, this is a really interesting thing that I'd like to say also, and to spread as an advice for some and many colleagues. Okay.
Professor Salvoni, thank you so much for a wonderful session. That's been absolutely fascinating. If you do have any other questions, that's all we've got time for live now, but if you'd like to email them in to us, please send them to membership.worlddentalcouncil@gmail.com, and we will get Professor Salvoni to answer any further questions that you have. Thank you also very much to our official sponsor today, IDC Dental Implants in Italy. Just a reminder before we finish that we have 2 sessions tomorrow. We will be listening to 2 renowned implantologists and key opinion leaders for Europe's leading brand IDC Implants Italy. So we've got Dr. Atef Ismail from Egypt. He's going to be speaking at 11 a.m. British Summer Time, and Dr. Tiziano Tealdo from Italy, who will be speaking at 1 p.m. British Summer Time. So please do join us for both of those sessions. Thank you again, Professor Salvoni, and we'll see you all tomorrow. Stay safe. Thank you.
Probably, yes, I will follow. Thank you.